So let me hit the record button here.
Is my phone sitting there somewhere? Is my phone sitting there somewhere?
I've got
Okay.
Dr. McManus on the line. Wonderful.
Yeah, how are we doing there? Okay.
So just to thank you, first of all, for joining us today. We hope to make this an hour that's going to be valuable for you. You know, we've had a great deal of conversations with many of you over the last number of weeks, both from Atlantic Health and the work that Dr. McManus and Dr. Williams and Dr. Allegra have all done as consultants and working with many of the post-acute facilities as we're dealing with the challenges of the COVID epidemic. And we felt there was an opportunity to really have a bit of a roundtable and really ask some of the questions that some of you have asked, but others have not, to try to get a basic level of understanding of some of the challenges we have dealing with this. So we're looking forward to be able to give you something valuable to take back with this. Just a couple of housekeeping items here. There's a question and answer tab that you can utilize to send in any questions to us. What we'll do is we'll monitor that, and then at the end of the discussion, we'll try to answer as many of those questions as we can. If we can't get through all of them, then again we'll try to answer them by email as possible. And again, we will do a linking to the recordings afterwards, so that there's an opportunity to continue to take a look at this as you feel the value of it may be there for you. So I just wanted to give you some background as to where things are sitting with the Atlantic Health System, with the 5 hospitals and what's been going on over the past 30 days. So as you can see from this graph here, the blue are the COVID patients that we've had coming into the facilities over the past month and some number of days. The orange are the number of non-COVID patients, and the black line are the number of patients who were on ventilators. And as you can see, thankfully, we are on the downside of the curve. The curve really hit somewhere around, April 12th or so, where we were at probably our highest level.
I don't see the slides advancing.
You don't see the slides advancing? Oh. I'm hearing that the slides are not advancing at the moment, although I'm seeing them advancing here. Hopefully there's a lag sometimes with the internet. Ed, do you see the slide with the graph on it?
No, we're stuck on the introductory page.
Ah, all right. Let's try this.
There we go. You just got it going.
Great. Okay. Thank you. Just have to click on a different area. Thanks. So anyway, just to show you, we did hit the high mark somewhere around April 10th, April 11th, and we thankfully are now on the downside of that curve. As you can see, really the ventilator patients have pretty much stayed in the same range, and that's pretty typical that what we've seen. It is drifting down somewhat, but nonetheless, patients who are on ventilators do tend to stay on ventilators for some period of time. Since March 9th, we've had about 898 COVID positive or PUI admissions that have come from the various post-acute facilities that we service. Of those, sadly, there has been a significant number of expirations in that group. And we know that you've experienced many more within your own facilities, patients that were not transferred, that were treated in place, who had advanced care directives, or who really continue to be under treatment and really have even recovered by now. And so, one of the first things we want to say is we really want to thank you and all of the healthcare heroes, all of your staff that's been working under particularly challenging conditions. Everybody was focused on the hospitals, and really, I really think that the post-acute facilities were kind of left out there a little bit. Not a little bit, but significantly in the ability of support from the state and from national, from both the standpoint of PPEs and guidance to how to deal with this. So I think you guys have really done a tremendous job in trying to respond to this with the population that's obviously the most frail and the most at risk as we go forward. So I'm done really talking. What we tried to do is pick a number of questions that we think have been brought forward, and would love to have Ed kind of respond to these. So I'm going to turn it over to Ed. I know one of the first questions was, you know, how do we even identify a patient within a facility likely to have COVID? We have more sense of that today than we had a while back. But Ed, I'll turn this one over to you.
Yeah, the identification of patients with COVID is evolving, and one of the most challenging things that we're going to have going forward is that it looks like a lot of other viral illnesses. You can see on this slide, we list fever as a very prominent thing, but you can see that the measure of temperature is just over 100. And so a lot of times, particularly in the elderly, they don't always show fever. And really for a nursing home setting, we're really all about cough and shortness of breath. Those are the two main findings that are really going to drive your diagnosis in the long-term care setting. Beyond that, then we're talking about fever more secondary, chills, or patients are complaining of chills, muscle aches, headache, body aches. All the symptoms we usually associate with flu are the most common that are going to be the presentation for patients with COVID. For the past month, virtually every patient who has those symptoms has COVID. And I think now it's going to get more difficult because we're going to have patients now having influenza, parainfluenza, other respiratory viruses. And so it'll be a much more mixed picture in terms of evaluating patients. But this is really, captures that group of patients who then should go on and be tested. And thankfully now, through the efforts of the state and businesses, we're going to have more availability and more rapid turnaround in terms of getting test results. Probably now, today, for most patients, we have a result within 24 to 48 hours. But we'll soon, in the next couple of months, have the ability to have an answer in 60 minutes with point-of-care testing. And we, along with all the urgent cares and outpatient settings, are all on a very long list to get these devices that will help us identify these cases quickly, because that's really the most important thing. The most important thing in terms of spreading of reducing the spread of cases is identifying cases and isolating them. We do have some nice recent information on some treatments, but those are not cures. And those are treatments that probably are going to be for patients who are sick enough to be hospitalized. So in the long-term care setting, the real key issue is identifying patients and isolating them and protecting the rest of the community from the virus.
I think
we move on to
sure. And obviously I think one of the big questions is who should be tested for COVID-19.
Yeah, I think we have, hopefully we have Steve Williams and Don Allegra on the line also that are going to help us answer some of these questions.
Steve's trying to get on. We're trying to get him the panelist email again. I just got a chat from him that he's trying to get on.
Okay. Well, I'll cover it until they're available, and I'm nearby Dr. Allegra, so if he's not tracked on, I'll just pass this on to him with my mask in place. So let's talk a little bit about New Jersey. The virus is very, very prevalent in New Jersey. We've identified about 130,000 cases in New Jersey, but I think that's just the tip of the iceberg. As you can see in this short blurb we have on testing, when they looked at some people in New York City just going to the grocery store and randomly screening them, 21% of the people just going to the grocery store were positive, and they were totally asymptomatic. So, and that's really why we've seen such a firestorm of disease in our nursing home settings. Our patients usually are, impaired and debilitated. They're not up and moving around. They're not necessarily coming in a lot of contact with other residents, but they are coming in contact with our healthcare workers. And we think that a large part of our issues in most settings is that our healthcare workers have asymptomatic illness. They don't know that they have it. And they've been probably part of the spread of the disease in these settings. Fortunately, most patients get better. 80 to 85% get better without any treatment at all. So that's to our benefit. And as I said when we reviewed the previous slide, the most important thing is identifying cases and isolating them to protect other residents. Okay. For the most part, we want to drive our testing based on symptoms.
And Steve is on the line, by the way. Thanks for joining, Steve.
Great. Let's go to our next slide. Okay, this is a slide that just shows you how the testing works in terms of from the day somebody first becomes ill and what tests are most helpful in making the diagnosis. And you can see that RNA by reverse transcriptase PCR, the top line, is your testing with the swabs. And you can see that that's most helpful in the first 1 or 2 weeks. And then it's probably less helpful in diagnosing somebody who's ill. And antibodies are a much better test for measuring whether somebody's having symptoms relatable or having disease over the past month. You can see that we have some short blurbs there, bullet points. Mostly we want to test people with a plan to what to do with the test result. We want to use the PCR testing when we want to confirm a case, when we suspect somebody has symptoms and want to test them. And we also want to use that test to screen patients who are going to have respiratory tract procedures or procedures that are involving intubation. In addition, we want to use it in the hospital setting in patients who are in labor and may be breathing hard. In the nursing home setting, we want to use that test potentially to help identify where a patient should be placed. So many programs are looking at testing patients, either asking the sending facility to test them before discharge or testing the patient on admission so that we can create a safe setting and know where that patient properly belongs. What we do have to keep in mind that having a positive test by this mechanism, though, does not necessarily mean the patient is contagious, but it's the best test we have right now. If we're going to talk about serum tests, we're really talking about people who might be able to donate their blood, who had COVID and now want to know if they have antibody, if they're a good candidate to donate plasma to treat other patients. We want to think about using our antibody test in terms of understanding the epidemiology and how this affected some of our facilities and our community. And we can also use that test to help answer the question, was I exposed? If you have staff members in your building who maybe were sick in the first week of April, their screening test with PCR is probably going to be 50-50 negative, even if they were sick. So the antibody test is a much better test to let you know and to reassure your staff, if you want to go that pathway, that they had the virus and either have survived it and are recovered. So let's move on to the next slide.
Sure. So I think one of the questions was, should all patients and employees of a facility be tested for antibodies? And if so, what's the benefit to the facility, patients, or employees? I think you've answered some of that, but I think there's still confusion out there and we've heard it, is that, even the state is kind of saying they want facilities to be totally tested on the PCR, and then we're hearing they want them to be totally tested on antibodies. And I think there's still a lack of clarity as to what's the best process going forward that's going to give you really actionable type of data that you can work on. I don't know if you want to comment on that.
I think the main thing there is it's got to be individualized. It depends on the site. It depends on how many cases are occurring at the site and where they are in their outbreak management. So I think that probably the best way is to look for the state for guidance, look for their medical directors to speak to an infectious disease consultant, or even reach out to us to get some concept of what might be more helpful. As I said, when you're doing testing, you really want to know, well, what are we going to do with the test results? Right. And that's a key factor in terms of determining what's the best testing strategy for your facility.
Yeah, and I guess the challenge is we see a lot of facilities where there's been partial testing that's occurred, right? So they've managed to do PCR testing on, say, 40% of their patients or employees. And then going forward, if you're kind of already down that path and you're trying to utilize this information to cohort or set up tiers, it almost argues that if you're already down that path wouldn't you want to try to get the rest of the facility done because you have that big question mark still that's sitting out there?
Yeah, I think as we said, it would depend on how many cases you have, how much testing you've already done, how much information you already have of your database. Obviously, you don't really need to retest patients who already tested positive. You have them properly cohorted. It's really about how you're going to create the safe zone in your building.
Yeah. And then, obviously staff are worried that even if they did have COVID, if they're assigned to a COVID positive unit, can they be reinfected? Are they still at a significant risk, even if they're COVID positive on antibody testing or serology or on PCR?
Yeah, let's include Steve here. You want to handle this and address this, Steve?
Yeah, I think, we don't really know exactly what antibodies do as far as protecting someone. We think that everyone probably has some sort of antibody protection for maybe a few months, maybe longer. We really don't know the answer to that. I think if someone has been exposed and had COVID, we would encourage them to continue wearing all the PPE and all of that and treat it as that you didn't have antibodies or you weren't exposed before. I think we aren't entirely certain what antibody protection means at this point. We do feel like perhaps most cases, in fact, maybe not all, or all, may provide some level of protection, the degree to which we do not know yet.
Great. And I guess the other question, Steve, is that question mark of patients or particularly staff, particularly younger, healthier staff, maybe, that, the challenge is that before they even show up on PCR or before they tested on PCR, they're actually symptomatic, right? And I guess it really does drive to the question of making sure that the level of PPE should be kind of at the highest level that the facility is able to manage.
Correct. I think, all of our cases here should have, high level PPE. If you're concerned, if you have a PUI or somebody has symptoms, but again, even the asymptomatic patients, which are symptomatic people, are people that we don't know about. But I think just exercising, good precautions with your PPE, wearing your mask, that should prevent most situations.
Great. Another question that was brought up was, how long can a patient remain COVID positive by PCR after transfer back to a facility? And how do we determine, when do we remove them from isolation or a COVID positive unit?
Steve, you've been working hard on that on some of the facilities. You want to cover that for us?
Yeah, this is a troubling issue because a lot of facilities and a lot of other places that are accepting patients want repeat testing, and these RNA tests can be positive for 1 to 2 months afterwards. We think they could be positive up to 6 weeks after first exposure. And so, but if you, the data on this, however, is showing that the virus is probably not present after about 10 days. So what you're looking at is a non-infectious, probably an RNA remnant or RNA shedding that you're seeing that's causing those positive PCRs down the road, those swabs that continue to be positive, but they're not necessarily indicating infectious virus. And those are probably gone after about 10 days. So I think we all think that probably a safe day is to say probably 2 weeks is probably safe enough to where someone's not infectious at that point. I think it does depend on the patient, if they were in the ICU or if they continue to have symptoms. I think those may have a little bit more virus going on, but I think as a general rule, most people do not have infectious virus after about 10 days. But they still may have viral shedding and viral remnants that would continue to be positive up to 6 weeks, which the swabs are not a good measurement of infectiousness.
So I guess it sounds like that, and I know when we've talked to different facilities, and especially since the hospitals are sometimes trying to send patients back as soon as possible, at least at the highest level of the surge. We had talked about that the patient initially needed to be a few days, symptom-free, of fever and symptom-free of pulmonary or much improved on their pulmonary symptoms, and at least 10 days out from the onset of the illness as it was defined. But then that kind of got tightened down as the hospitals got tightened. They were starting to send some patients over that, you know, were like 24 hours. And I think that the general thought was at least when those patients came over, that at least after they were symptom-free was an additional 14 days of isolation. And does that kind of still hold?
That kind of still holds.
Great. Okay.
Yeah, it's probably important, Tom, for us to make a note now that of today's date, May 6th, because this is changing so fast. If you're watching this on a tape delay, the rules may have changed.
Right.
So please check with your local health department on what rules they're following. CDC has two mechanisms that they look at, test-based and time-based. And currently the time-based and symptom-based strategy allows you to return to somebody out of isolation 10 days from the beginning of their symptoms, as long as they're fever-free, symptom-free for 3 days. We've been more conservative. Two parts of that. First of all, very few of our patients can tell us exactly what day their illness started. So we've generally said started the clock on the day they were tested. And then we've been a little more cautious than the CDC recommendations and said, let's wait a full 2 weeks from the test if you haven't been hospitalized. If you have been hospitalized, obviously you were sicker and probably had a high viral load. And we think those patients should have a 14-day block of time where they're in a COVID unit until they're cleared for isolation after transfer out of the hospital. And then the patients who've been on a ventilator, we think those patients need to be sort of individualized because they've been most severely ill. And we really don't understand their illness very well because part of it is immune, part of it is a virus. And so those cases should be probably individualized when they can come out of isolation. Great.
Just to remind everybody while we're going through these questions, again, if you have any questions that you would like to have asked, you know, please put them in the question and answer piece and on the screen, and we'll try to get to them before the end of the webinar. So, you know, the other tough area is the PPEs, right? You know, the questions have been, and obviously it's a lot there, is how do you use them? How do you maximize their use? And I think what we've heard from a lot of facilities is that the gowns are one of the things that really have become in short supply. So any guidance that you can give there?
Well, I could answer a part of this. I think, you know, I think that probably having dedicated COVID rooms and units probably, or floors and wings probably does help with some of the limitations in PPE. I think if you have a situation where you're kind of going, you're taking care of the same patients, but you're changing your gloves in between patients, that you could still wear the same PPE and use those between patients as long as you change gloves and you do some sort of hand hygiene between patients. That's kind of been the strategy for a lot of facilities to kind of help preserve their PPE. Gowns are particularly short supply, and some facilities, they've gone to washable gowns where they use the gown for a day and take them and wash them. And that's been a particularly good strategy because they're a little more comfortable. They breathe a little better. People are more comfortable, especially if you have several COVID patients on that floor. It allows you to wear that a lot longer and not be as uncomfortable. And I think if you have a big supply or you have several patients that are COVID positive, you know, probably keeping them all on one wing so that you can strategize this to where you preserve your PPE by using just gown up for several patients and take care of them, whether you're passing medications or whether you're administering to them in some other fashion, maybe even doing physical therapy. All of that, I think wearing kind of one set of gowns does help.
Great. And another question that had come up is, you know, when can staff who did test positive, you know, safely return to work? When is a safe time for them to come back?
Yeah, let's give Don a chance to answer this. He's online, I think. Don, are you able to answer?
I don't see Don in our panelists section.
Okay. All right. I thought he was able to sign in. All right, so let's cover this. A lot of this is regulated from the CDC and from your local health departments. And there's been some recent changes. Last Thursday, they came out with some new regulations. The most significant one is that if you have an asymptomatic healthcare worker who tests positive, they should be out for 10 days. And that's just a straightforward, that's the strategy. And in fact, most strategies are moving towards that. In patients who are symptomatic, first of all, they have to have recovered, and then they can return to work. And we've usually recommended that they can return to work 7 to 10 days after the onset of their illness, as long as they have no fever for 3 days prior. But they do still need to continue to wear a mask, as we all are wearing, to protect spread. And they also should be cautioned that they're a risk at home, so they should be wearing a mask at home so that they don't spread the virus further in their home setting.
Great. One of the good questions that did come up is, thankfully, hopefully we're all on somewhat of the curve where we're starting to see less new cases and that type of thing. And unfortunately, we're still going to have the new normal, which I'm sure we'll always have some new COVID patients coming along. But one of the questions is if, indeed there's a second surge of cases that is going to occur in the fall, what kind of things should facilities be doing now to be really prepared for that return in the fall if we see another surge of activity?
Well, I think everybody is trying to purchase and have enough product and PPE so that they're prepared for the outbreak issues in the fall. I think one thing that's going to help is more rapid testing turnaround. One of the things that burned through a lot of materials is that we weren't sure who had it. And I think we'll have more confidence with better testing in the next 3 months to be better prepared. So part of the strategy is to know what your channel of testing is going to be and keep that updated with your infection control coordinator so that that person is well able to access testing when we have an outbreak of symptoms going forward.
Great.
I would add a little more to that. I would also probably encourage facilities to look at the febrile patient. So as you get patients that do start to mount fevers, more than 100, what you do with that patient. Do you just, give them an oral antibiotic? I think trying to think a little bit about, could that patient be also a COVID patient? And I think that should probably trigger a response to maybe putting them on isolation at that point. When you do get the febrile patient in the facility, maybe adding that to your sepsis protocols and moving towards a situation where you're not only doing testing, whether you're doing blood work or other modalities like chest x-rays and stuff like that for your febrile patient in the facility, also incorporating something like isolation and more of a quarantine for that patient until you kind of have better data to move forward in that setting. So I think, a two-prong approach, testing and then maybe even testing those patients next, and to make sure that they're not, a COVID patient, and then moving forward with that with your rest of your workup for the patient that becomes febrile or septic while is in the facility, if they are going to stay there.
Yeah, I guess that's going to be a real challenge as we get into flu season in the fall, right? And
right.
What we used to think was the really bad thing is now not quite as bad as some of the others, obviously.
Right.
There was a question that came in through the chat section, the question and answer section is can you give us any idea what the current guidance is right now for treating in place for some of the moderately ill patients? I know there's been a lot of question of is chloroquine, hydroxychloroquine, still something that should be used in this population based on some of the new information?
I think I can take that. Unfortunately, I was unable from my own computer to sign on, so I'm on Ed McManus's. Can you all hear me now?
Absolutely, glad to have you.
Okay. Basically, I think there's a very good question because, we've tried lots of different treatments for this disorder, but nothing really has been like a game changer. Initially, hydroxychloroquine or Plaquenil was felt to be effective, and there was some early studies showing that it was at least moderately effective. But subsequently, it's sort of been a little bit iffy whether it works or not. And then there's been a lot of warnings about the potential cardiac effects, particularly when you combine Plaquenil with Zithromax, which both can prolong what's called the QT interval on the EKG and lead to arrhythmias. So generally, I think some of my facilities are still using one of the drugs, and I would recommend if you're going to use one, use Plaquenil alone rather than a combination of Plaquenil and Zithromax. And because the patients are sort of fragile and a lot of them are in their 70s and on drugs which potentially could precipitate arrhythmias, sort of like amiodarone, some of the antidepressants, and some of the anti-seizure medicines. You don't want to give these in combination with hydroxychloroquine. So some of the facilities have said to me, well, we're just not going to even go with this since there's very little data showing that they're really effective anyway. So I've taken an approach that if you are going to give it in a nursing home setting, you really should get an EKG beforehand to prove that the QT interval is not prolonged, and make sure that they're not on other medicines that could also affect their heart. And then if you have that situation, then go ahead and give Plaquenil. But if you're concerned about the cardiac risk factors, then in those situations, I probably would not give it. And in terms of other things, there's been vitamin C, zinc, and a whole bunch of other things that have been recommended, Pepsid, and also some of the drugs that lower cholesterol and so on, but the statins. But all of those really have not been actually officially proven. So I think that supportive measures are probably the best measures. The other thing I would warn about is that a lot of elderly patients I've noticed will be stable for several days and all of a sudden go very rapidly downhill. So if you have a COVID patient in your facility, I really would recommend that you follow their O2 sats very carefully, because it can happen very quickly where they go downhill and may need to really have high levels of oxygen very quickly. So on all those COVID patients, I think we should be doing O2 sats every shift to keep an eye on them.
Great, thanks, Dan. I think it also, one of the things that obviously early on and even today, I think there's still a challenge with is the understanding that those patients who really get into trouble, particularly who get that, that cytokine surge and really go downhill at that 7th or 8th day, that, what we found is many of those patients, if they wind up in the hospital, particularly if they wind up on the ventilator, the mortality rate is so high on those patients who are on the ventilator. And then the quality of life, even if they come off that ventilator, is substantially different. So, we continue to urge all of our physicians that are on staff at these facilities that the old days of the advanced care plan that was, do not resuscitate, do not intubate, but send to the hospital for supportive care, probably does not make as much sense in this particular situation for some of those patients. I don't know if you have any thoughts on that.
Yeah, Dr. Kloos, can you see me now?
Yes.
Okay, good. Yeah, I think you're right. We don't really have great treatments for this disease. And once you get on a respirator, as you pointed out, the mortality is extremely high, particularly in the elderly population. We've discovered in hospitals that proning patients, which is lying them on their stomach, does seem to improve oxygenation. And that could even potentially be done in a nursing home, but it does require a fair amount of nursing support to turn people, particularly if they're overweight. So anyway, I think that all we can really do is just support them pretty much and see how the illness progresses really, either in a nursing home or in the hospital.
Great, yeah. And I think it's really just having those conversations earlier with family members, not you know, at the crisis moment, even though it may be the family member will say, is my, you know, if you call them and they say, well, why are you calling me? Is my father going to die? Well, no, you know, but you have to understand that the nature of this beast is that if something suddenly gets a lot worse, you know, what does your dad or what does your loved one really want, or what have they kind of talk to you about? So I think we continue to try to see that, because we have seen still that, you know, unfortunately, a number of patients come into the hospital. The DNR then is obtained in the hospital, and you know, and unfortunately patients pass away. But at the same time, you know, there are patients that get through it. There's no question about it.
So I'd just like to add just one thing to that. I've encouraged when patients are diagnosed with COVID or PUI, I usually encourage the attendings, the primaries that are taking care of those patients to really update their pulse status and to discuss end-of-life issues as soon as they're diagnosed, so that you can kind of be upfront with them about what the expectations are, you know, that this is a serious illness, and you know, where things could go at a certain point. Now, that doesn't always work in all circumstances, but I try to really get on top and get out in front of this before we get into situations where you have somebody that is being transferred to a hospital and now they're wanting to intubate. So I think it's better to actually get that discussion out front as soon as the diagnosis is made, or when they're considering it.
Yeah, no, I agree completely with you. Another question that has come up is that I know, as we've seen more and more of patients that are coming back from the hospital to the facility, that many of them now are on our DVT prophylaxis because of some of the issues related to that. Any sense of how long that prophylaxis needs to continue once they're back into the facility?
Yeah, well, for patients who go home, we've recommended 2 weeks. For patients who go to a facility, we think it probably should be 4 weeks. We've seen that there's been a lot of complications related to thromboembolic disease with COVID. And we've seen, I think, benefit from being more aggressive than a lot of our colleagues in continuing them, usually on a low dose of Eliquis or Xarelto as the optimal choices. Usually when they're in the hospital, they're on Lovenox, but I think that the oral agents are probably quite effective in that setting. You also may see that some patients are continued on some of the statin drugs, atorvastatin, 40 milligrams daily. That's also been continued for about a month, because there seems to be some possible benefit from regulating the statins and cholesterol levels in terms of how the receptors are expressed on cells and the severity of the disease.
Great. There was a question that came in about any information on vitamin D levels as supplementation for this.
Don, do you want to cover that?
I think we lost Don again.
Okay. So
I cover it. I don't know that there's any data that supports that. Are you aware of anything, Ed?
no, I think that, but it is often a deficiency in a lot of our long-term care settings. So it's probably a good idea to be aware of that, you know, and we still don't have any spring or summer weather to put them outside to get some natural vitamin D. So supplementing it is probably helpful.
Right. There was also a question that came in that, do you have statistics to help families with goal of care discussions, such as if my mom were to get admitted with COVID and put on a ventilator, what will be the likelihood of her surviving through that process?
Well, the statistics on that are very dismal. You know, most of the time we refer them to the website Vital Talk because there's good conversational points that help people think about that or understand that. You know, when you get to a certain age and a certain level of activities, there is going to be something that is a terminal event at the end of your life. And for many people, this will be one. And so recognizing that if not this, then some other event is going to happen in the next number of years. It is tragic that when we look at patients who do have a mortality, that the average amount of time lost of life is about 11 years. So this is not just, oh, the person would have passed away next week for something else. This is really changing the endpoint for many people, but it is an important time to think about, you know, what values one has and what values the patient might have, because I think sometimes people get caught with they try to make a decision of their own, and really their job as a surrogate is to tell us what the patient would express to you and what their wishes would be if they could step aside and see the situation they're in.
Great, thank you. Just looking if we have any other questions here. There was a question that came in actually more, when will the recording of the webinar be available? They're thanking the panel. They feel that this information was very pertinent and very important. We will be uploading the webinar today. It should hopefully go on to the site where you'll need a link. That'll be open not just for ACO providers, but for everybody. So we will try to get that out in an email, hopefully later today, so everybody has the link so they can utilize that as we go forward. Just trying to see if there are any other questions that we have in the queue here. We have one more that just came in. So the question is, in the nursing home, we have now tested every resident, are moving and cohorting residents, and continue to screen positive and negative residents for symptoms. We are close to admissions, however, are close to opening an admission quarantine unit for new admissions who are COVID negative patients. What process is the hospital following in terms of screening patients? So, and I'm not sure if you can answer that, Ed, or I can try to take a stab at it. I know that I think right now, I think the challenge still remains the ability to get rapid turnaround testing even done in the hospital. So I believe, you know, the goal will be eventually to be able to, if we get more rapid turnaround testing, or if we know a patient is going to be going discharged, I believe the goal would be to try to get those patients tested to confirm that they're not COVID positive, you know, before they're sent to a facility. But I don't think we're quite there yet. I think that's the goal that hopefully will be there as we're starting to see the turnaround time and some of the testing capabilities continue to increase.
Yeah, I think at the hospital, for anybody undergoing a procedure, they're going to be screened.
Right.
So I think that's going to be a baseline of information. I think that patients who are medically admitted, depending on the nature of their illness, they'll be tested if they have symptoms that are suggestive, but they may not have a test in their record if they didn't have direct symptoms. So I think it's, you know, it's reasonable to think about what your strategy is at your site. I think it's fine to ask the sending facility, you know, would you test the patient so we know their status? But if they're not going to test them, just test them when they arrive at your facility and keep them in that admission unit until we're comfortable and confident that we know what site to put them in. I think that the real key for what patients are going to want is they're going to want to know that they can come to some part of your facility that is COVID-free and COVID-safe. Because all of you, I think, have created COVID units that we're going to manage the COVID recovery patients. And I think that's what is probably a worrisome thought for the patients who don't have COVID, who are going to have procedures or the need to rehabilitate in your sites.
Right.
Just as a caveat to that, for the quarantine units, I think that's, you know, that's a great strategy. You know, trying to test people. You know, I think two strategies of accepting patients that are non-COVID. One would be to test them when they come in the door if they haven't been tested already. I think that should be reserved for people that are probably going to have a stay of, you know, a shorter stay. And I think the longer stay patients, I think the quarantine units are a good idea. And I would probably encourage that to be a quarantine of about 14 days, at least to watch them in that setting. You know, you can test them as well. I guess the concern would be that if you test them today, they could still be positive in 2 days, and you would miss that person. So I think, you know, you could do one of two strategies, which is have your quarantine unit where you have your patient, maybe you put them in the yellow zone where they're watched, their contacts to a case, and then you watch them for 2 weeks, or you test them immediately, or they test them from the hospital. And I think both strategies would be fine in my book for new admissions coming from the hospital that are non-COVID. Your COVID patients, it's a known entity. To put them on a COVID unit and you isolate them. The non-COVID patients, I think, are the the more concerning patient to accept, just because you don't necessarily know. Even if they're negative today, could they be positive in 2 or 3 days? I guess that's always that possibility. And kind of being able to watch them a little closer is key.
Great. One quick question here. What about remdesivir? But I think that really is more an inpatient than an outpatient or a long-term care strategy.
For now.
Yeah. So I think I did get a note from Jan Schwartzmiller, who's also listening in. Unfortunately, I can't put her on. Open it up to her, but it's that question about testing admitted patients is something, again, that the health system is trying to look at seriously as a way of kind of getting that information out for someone that's going to be transferred over to a facility before transfer. So we'll try to give you more update on that as we move forward. I think that's all of the questions. I had a couple other comments that it's been an excellent webinar, great value. They want to make sure we have the recordings. There was a question about Vital Talk, and I know we've sent out a link to that before, and we'll make sure we send that out when we send out the link to the actual recording. So unless we have any other final comments or so, I do want to thank everybody that our panel, Dr. Williams, Dr. McManus, and Dr. Allegra. I think this has been exceptionally helpful to give us some guidance. I also will remind everybody, I think your point was well taken, that this is as of today, May 6, 2020. And even if you listen to this webinar 3 days later from now, things may change. So it's important to continue to stay up to date with both the New Jersey Department of Health site and the CDC to ensure that we're up to date with the most recommendations, since this obviously remains an exceptionally fluid process. Any other comments from you gentlemen before we sign off?
Tom, I think there's a late night slot available for you as a host. Thanks so much.
All right, well, thank you so much, and thanks everybody for joining, and we'll get the information out to you soon. Have a great day.